Predictive Power, Analyzing the Efficacy of Claims-Based versus EMR-Based Algorithms for Readmission Risk. Christina Mayberry. Hospital readmissions are a pressing issue in healthcare. Nearly 20% of patients are readmitted within 30 days, and this statistic demonstrates not only the clinical challenges, but also the human and financial costs. These readmissions often stem from preventable causes like poor care transitions, untreated comorbidities, and inadequate follow-up. In addition to the impact on patients, readmissions impose a financial strain on the healthcare system. CMS has implemented programs like the Hospital Readmission Reduction Program, which penalizes hospitals for excessive readmissions. With an annual cost of over $52 billion, reducing readmissions has become a necessary goal under value-based care models. Identifying high-risk patients early is key to breaking this cycle. Predictive algorithms offer a solution by leveraging existing data to forecast readmission risk and enable targeted, timely interventions. However, not all predictive tools are created equal, and the challenge lies in determining which algorithm can deliver the most accurate results. This project addresses this challenge by comparing two predictive algorithms, EPIC, an EMR-based tool, and SHP, a claims-based tool, to assess which better identifies high-risk patients in home health. The findings have implications for improving care, reducing cost, and aligning with care-based initiatives. Readmissions are not just numbers. They represent patients returning to hospitals, often facing worsening conditions. For healthcare organizations, these frequent rehospitalizations translate into strained resources. The burden is especially heavy on home health agencies, which must manage these complex patients effectively to prevent their return to acute care. Identifying high-risk patients often relies on the judgment of individual clinicians. While clinicians bring invaluable expertise, relying solely on their insights can be subjective and inconsistent. Without tools to analyze broader patterns in patient data, key indicators of risk may go unnoticed. Preventive algorithms offer a systemic way to address these gaps. By analyzing patient data, algorithms can forecast the likelihood of readmission. This helps clinicians prioritize their resources, focusing interventions where they're needed most, and ultimately reduce the number of patients returning to the hospital. This project focuses on evaluating two such algorithms. Both were readily accessible by the home health agency, but their effectiveness in preventing readmissions had never been directly compared. The goal was to determine which algorithm performed better in identifying high-risk patients so that interventions can be more accurately targeted. EPIC is widely used in hospital systems and leverages detailed patient-level data from electronic medical records. It calculates risk-based scores based on comorbidities, recent emergency room visits, and some social determinants of health. By contrast, SHP analyzes claims data, offering a broader perspective by including data beyond the hospital system, but less tailored to the individual patient. By identifying the superior tool, this project aims to improve patient outcomes by targeting interventions to those most at risk. For example, patients flagged as high risk could receive additional visits, medication reviews, or case conferences. This proactive approach aligns with CMS's value-based care initiatives, which tie reimbursement to outcomes like readmissions. Beyond financial incentives, this project also seeks to enhance the patient experience by helping them remain in their homes. The findings from this project not only support the home health agency's efforts, but also provide a framework for other agencies to adopt evidence-based predictive tools. The goal is to integrate the best tool into agency workflows, ensuring that the right patients receive the right care at the right time. Research, like that of Lowe et al., points out the significant savings that predictive tools can offer in value-based care models. Also, findings from Garcia indicate that proactive interventions facilitated by these algorithms can greatly decrease hospital readmissions and enhance patient outcomes. The literature review also revealed weaknesses in algorithms in healthcare. Darby et al. Demonstrated the challenges in generalizability stemming from the variability in data sets, which complicates the application of findings in various healthcare environments. One significant challenge lies in the opaque nature of some algorithms, as noticed by Divana et al. The absence of clarity can hinder their effectiveness for healthcare professionals. And McKay et al. Emphasized that the limited sample size and specific demographics in some algorithms diminish the wider relevance of these tools. It is important to understand these strengths and weaknesses when selecting and integrating predictive tools in healthcare. The Donabedian model was chosen as a theoretical framework for the structure because it provides a structure for evaluating healthcare quality. Its triad, structure, process, and outcome, is well suited for examining the role of predictive algorithms and identifying and managing high-risk patients. In this project, structure refers to the foundational elements that make care delivery possible. This includes the SHP and EPIC algorithms, and the organizational infrastructure of the hospital-affiliated home health agency, which integrates these tools into its workflow. Without this structure, the predictive tools would not have the capacity to generate meaningful insights. The process element focuses on how the predictive tools were implemented within the home health agency. The project evaluated how SHP and EPIC algorithms were used to identify high-risk patients on admission, and the collaboration between clinical staff and leadership to ensure the tool's effective use. By optimizing these processes, the project aimed to bridge the gap between algorithm predictions and actionable interventions. Finally, the outcome is the tangible result of implementing the structure and process effectively. The long-term outcome is to reduce hospital readmissions by using the best-performing algorithmic tool to identify high-risk patients. By utilizing the Donabedian model, this project illustrates how advanced practice nurses can lead initiatives that combine clinical expertise with technological innovation. It emphasizes the APN's role in assuring that predictive tools are not only integrated into practice, but deliver measurable improvements in patient outcomes. This project used a quantitative, descriptive, retrospective design to analyze the data from home health patients admitted in Q4 of 2023 to compare the predictive accuracy of SHP and EPIC algorithms. The population consisted of 1,094 patients who were discharged from a single hospital system and referred to home health care. Inclusion criteria required patients to be insured by Medicare, Medicaid, or Medicare Advantage, which aligns with the focus on populations at high risk for readmission due to age, comorbidities, and social determinants of health. Data was drawn from two predictive algorithms, EPIC, an EMR-based tool, and SHP, a claims-based tool. This dual approach examined the differences in predictive accuracy between a single system and a claims-based algorithm. The primary outcome was to determine the correlation between the risk scores generated by each algorithm and actual 30-day readmissions. By doing so, the project aimed to assess which algorithm more accurately identifies high-risk patients to support targeted interventions. The project leveraged two key data sources, EPIC, the EMR-based tool that calculated risk scores using patient-specific clinical data, such as comorbidities, recent emergency room visits, and other social determinants of health, documented in the electronic medical record. SHP, a claims-based tool that uses data from Medicare, Medicaid, and OASIS assessments. SHP evaluates a broader data set that includes healthcare utilization outside of the hospital system. Inclusion criteria: it included patients who were discharged from a single acute hospital and referred to home health between October 1st and December 31st, 2023, who had Medicare, Medicaid, or Medicare Advantage insurance. Exclusion criteria for patients who transitioned to hospice within 30 days of admission to home health or expired during the study period. These exclusions were necessary to ensure consistency in data, as risk scores from EPIC could not be retrieved after EMR closure. Data collection process. This process involved several steps. First, a list of eligible patients was generated from the home health agency's records. Next, each patient's risk score from EPIC and SHP at the time of admission to home health was recorded. Finally, claims data was reviewed to determine whether patients were readmitted to the hospital within 30 days. To maintain data integrity, only de-identified data was collected, and a single researcher managed the data extraction to ensure consistency and accuracy. Data was stored securely on a password-protected system with IRB-approved measures in place to protect confidentiality. The project's finding indicated that SHP claims-based algorithm outperformed the EPIC EMR-based algorithm in identifying patients at risk of rehospitalization. This was consistent across all statistical measures used in the analysis. Point-by-serial correlation to measure the relationship between algorithm-predicted scores and actual readmissions. SHP showed a significantly stronger correlation, 0.191, 0.001, compared to EPIC, 0.072, p 0.017. This means SHP's predictions were much more closely aligned with actual outcomes, providing a more reliable tool for identifying high-risk patients. Effect size is measured in the magnitude of difference between readmitted and non-readmitted patients' risk scores. SHP demonstrated a small to moderate effect size, indicating it effectively distinguished between high and low-risk patients. In contrast, EPIC had a smaller effect size, reflecting weaker differentiation in its risk scores. This reinforces SHP's superiority in discriminating high-risk patients. SHP exhibited a greater divergence in risk scores between readmitted and non-readmitted patients. This means SHP was better able to identify the patients who were most likely to be readmitted, which is vital for prioritizing interventions and allocating resources effectively. The point-by-serial correlation showed that SHP's risk scores had more of a meaningful relationship with actual readmissions, making it a better predictor of outcomes. The Mann-Whitney U-test analyzed how well each algorithm distinguished between high-risk and low-risk patients. SHP showed a larger divergence in risk scores between readmitted and non-readmitted patients, indicating a statistically significant difference. EPIC had a smaller divergence in scores. While statistically significant, its effect was much smaller, making it less reliable for distinguishing risk levels. These results highlight that SHP is not only more accurate, but also provides actionable data. Its ability to clearly differentiate between high-risk and low-risk patients ensures that resources can be allocated effectively, enabling early interventions and better care outcomes. SHP demonstrated a stronger ability to predict hospital readmissions compared to EPIC, with higher correlation coefficients and larger effect sizes. This difference can be attributed to SHP's use of claims-based data, which offers a broader view of the patient's healthcare journey, including utilization outside the hospital system. EPIC's reliance on EMR data, while detailed, is limited to a single system perspective. These findings have a direct impact for advanced practice nursing. By integrating SHP into the home health workflow, advanced practice nurses can use the most effective tool to identify high-risk patients and implement early, targeted interventions. This aligns with the core nursing principle of providing proactive, patient-centered care. Beyond this single project, the findings have broader implications. It can serve as a model for other home health agencies looking to reduce readmissions, increase star ratings, and improve patient outcomes. These results advocate for the use of claims-based data in predictive analytics, which could influence future development in risk assessments for home health. Other unexpected benefits of this project was the development of a real-time EPIC report to monitor readmissions and the further integration of SHP high-risk alerts. While not part of the original objective, these tools have become valuable assets for tracking and addressing readmission trends daily. This project wasn't without its challenges. One major limitation was the exclusion of deceased patients. EPIC's system automatically closed EMRs upon a patient's death, making their risk scores inaccessible for this study. Many deceased patients likely had higher risk scores and a history of readmission prior to their passing. Their exclusion concentrated data towards the lower end of the spectrum, creating a floor effect that skewed the results. To mitigate this in future studies, researchers could collect real-time risk scores at admission or explore alternative methods for accessing post-humorous data. The constraints of this data source also pose challenges. While SHP provided a broader data set from claims, the 90-day lag in claims data processing limited the timeliness of data analysis. EPIC, although detailed, EPIC is confined to a single system EMR data, which doesn't account for patient activity outside of the hospital system. This restricted its ability to build a comprehensive patient risk profile, likely affecting its predictive accuracy. The challenges of a retrospective study design in that it relies on pre-existing data, which can limit control over data's completeness and quality. And so, the study was dependent on the accuracy of previously entered EMR and claims data, introducing potential error for bias. While the study was cost-effective and feasible within the project's scope, a prospective study might offer more insights by integrating claims and EMR data to enhance predictive accuracy by leveraging the strengths of both systems. And real-time data collection and admission would ensure inclusion of all patient groups, including those that may pass away during the study period, ensuring data completeness and improving the reliability of results. This project exemplified how advanced practice nurses can leverage predictive tools like SHP to enhance their role in patient care. The predictive capability of algorithms supports evidence-based decision-making, shifting the focus from reactive to proactive care. Integrating findings such as this study into practice reinforces the leadership role of APNs in managing complex patient populations and coordinating care across interdisciplinary teams. The results of this project provide clear guidance for practice improvements. Full integration of SHP should be embedded into the home health agency's daily operation. High-risk patients identified by SHP can be flagged in daily huddles, ensuring that clinicians focus on these patients. Once flagged, these patients can receive tailored interventions such as increased visits, med management, and multidisciplinary case reviews. SHP's predictive data tool allows for the efficient use of resources by directing the care to patients who need it most, aligning with the principles of value-based care. Sustaining the impact of this project starts with integrating SHP into daily workflows. That automatic notifications are generated daily to identify when a patient is high risk. This ensures timely awareness and action without relying on manual tracking. High-risk patients flagged by SHP have become a standing agenda item in daily huddles, where case managers and clinicians can collaboratively plan interventions. Current staff have been educated on how to interpret SHP data and implement target interventions for high-risk patients. SHP training has been embedded into the orientation process for new nurses to ensure that all team members, from day one, understand the importance of predictive analytics in achieving value-based care goals. Sustainability also requires active involvement from leadership, and regular updates are presented to leadership on readmission rates, high-risk patient outcomes, and the effectiveness of interventions help maintain the organizational focus on readmission prevention. The findings of this project were shared with academic audiences to contribute to the body of knowledge on predictive analytics in healthcare. Poster presentation has been completed with peer engagement. Within the home health agency, findings were disseminated to leadership and staff to promote SHP integration with results shared across departments to ensure that the clinical and administrative teams understand the value of SHP and actively support its integration into workflows. Beyond the agency, the findings will be shared with broader professional and policy-making communities. Findings on this project were presented to the Missouri Alliance for Home Health and Hospice Care, so other agencies are informed of SHP's potential benefits. This could drive adoption across the state, creating a collective impact on readmission rates. The data from this project can support advocacy efforts for broader implementation of predictive tools like SHP. By showcasing the effectiveness of claims-based algorithms, we can influence policy discussions around home health reimbursement models and quality improvement initiatives. The findings from this project are clear. SHP claims-based algorithm demonstrated superior predictive accuracy compared to Epic's EMR-based model. By integrating SHP into the home health agency's daily operations, clinicians can better identify high-risk patients, enabling timely interventions that reduce hospital readmissions and improve outcomes. This proactive approach aligns with the agency's goals of improving quality care while maintaining financial sustainability under value-based care frameworks. This project highlights the evolving role of advanced nurse practitioners in driving innovation. By adopting predictive tools, nurses become pivotal in operationalizing data-driven care strategies that optimize resource allocation and enhance patient outcomes. This project exemplifies how advanced practice nurses can lead initiatives that integrate clinical expertise with clinical advancement, positioning nurse practitioners at the forefront of healthcare transformation. Ultimately, this project demonstrates that predictive analytics is not just a tool for improving metrics. It's a means to enhance the lives of patients by keeping them in their homes, supported by tailored, high-quality care. By continuing to refine these tools and processes, advanced practice nurses can lead the way in transforming healthcare for the better. References: Acknowledgements with gratitude for support and collaboration. Home Health Leadership Team, EPIC Team for technical guidance and real-time support, SHP Senior Customer Manager for training and resources, academic mentorship from faculty advisors and my project chairperson at Maryville University, team collaboration, clinical and administrative staff at Home Health, and personal support, family, friends, and colleagues who provided encouragement throughout the project. Thank you.